Good evening and welcome back to the Lipid Panel. My name is Dr. Guy Mintz and I'm the co-chair of programming for the Lipid Panel, working today with Chloe Mativi from the NLA. The Lipid Panel was conceived to be a lipid clinic conference for everyone. Not everyone has access to a large tertiary care center, and it's a great way for us to share cases with colleagues, therapeutic ideas with colleagues, and just to debrief about various cases that we may see. So it's an opportunity for us to work together. So if anyone has any thoughts for future lipid clinics or want to participate in lipid clinic, please reach out to Chloe. So tonight's program is on inflammation and residual cardiovascular risk, hot stuff. This is our last lipid panel. We'll restart again in September. And tonight we're honored to have Dr. Peter Jones as our moderator. Peter has worked for 41 years in the Center for Cardiometabolic Disease Prevention at Baylor College of Medicine. He was former president of the NLA and chief science officer of the NLA. He was awarded the honor of Master of the NLA. Our case presenter, Laura Gantt, graduated from UNC School of Pharmacy and completed a residency at Mission Hospital, Nashville, North Carolina. She works for Cardiology Associates in ambulatory settings, supporting optimization of medical regimens and improving access to pharmacotherapies. She's currently working in a dyslipidemia clinic. Dr. Michael Garshick is a cardiologist and assistant professor at New York University Grossman School of Medicine with appointments in both medicine and dermatology. Dr. Garshick has interests including mechanisms to explain the heightened risk of cardiovascular disease in patients with immune-mediated inflammatory diseases, specifically focusing on platelet activation and endothelial cell damage in patients with psoriasis. He conducts clinical trials and directs the cardiorheumatology program at NYU Langone. Dr. Jorge Plutzky directs the Brigham Women's Preventive Cardiology Program, which includes their Lipid Prevention Clinic, which is a high-volume referral center for lipid cases. He is a prior American Heart Association Diabetes Committee Chair. He served on various steering committees for international clinical trials, including the SELECT trial and CLEAR trial with bempedoic acid. He's also been involved in NIH studies investigating cardiovascular risk and obesity, rheumatologic disorders, and HIV. Dr. Plutzky also directs the Basic Science Laboratory studying transcriptional programs involved in cardiometabolic disorders. He participates extensively in the education and mentoring programs, including as prior scientific committee chair and current board member of the Sarnoff Cardiovascular Research Foundation. So without further ado, let me hand the program over to Dr. Peter Jones.
Well, thank you very much, Guy. I really appreciate having the opportunity to be the moderator for this last session of the lipid panel for this year. And I'm very honored to be here with some great panelists and discussants as we take a look at the role of inflammation and its role in residual cardiovascular risk and major cardiovascular outcomes. And we've got several case presentations that we're going to have this evening, and we're going to use those to initiate our discussion and then have all of our panelists probably have their input in, and hopefully you'll learn a lot from it. We also have some polling questions that are important as in order for you to get your CME and requirements out of this. So please participate in answering the polling questions. So first of all, I'm going to turn it over to our first panelist, Dr. Garshick. Michael, will you please start us off this evening?
Sure, that sounds great. Thanks so much for the invitation to speak today, and I'm really honored to be a part of this panel. So I'm not sure if the slide's up right now, showing the first slide, but this is called the lipid panel, and the question is, though, we're actually the topic of the talk today is inflammation residual risk, and so I wanted to frame the picture, which is the relationship between inflammation, dyslipidemia, and atherosclerosis. So this is the lipid panel, and of course, we still fundamentally believe that you need a lipid exposure. And then after that, you get endothelial damage. And that one way that endothelial damage can occur is via chronic inflammation. So then the lipids, they actively translocate into the intimal space. And then you have monocytes that translocate into the intimal space, and they phagocytose those lipid particles, and then you're off to the races with the initiation, the progression of atherosclerosis. So really, at the most basic level, inflammation can occur in two different ways. One is endothelial damage, which can accentuate and potentiate atherosclerosis, and the other is immune system activation, whether it's with monocytes, macrophages, T cells, etc. And if I could have the next slide, please, on this, showing the central illustration. So monocytes are obviously very important in this process. And monocytes carry this one protein complex, or this systolic multimeric protein complex called the inflammasome. And you're going to hear a lot about the inflammasome today. And I kind of joke that cardiologists really aren't immunologists. But if there's one biological pathway that we want cardiologists to recognize, it's the inflammasome pathway. And this inflammasome pathway becomes activated, whether it's mostly in monocytes. And you can see how that monocytes are really this key important pathway in the initiation and the progression of atherosclerosis. So really, this is how this interacts between endothelial damage, dyslipidemia, and in the immune system accentuates atherosclerosis, and why it's so important. And I think we can go on to the first case.
Okay, thank you again for having me, inviting me to speak. I'm very honored to be here, and I'll present the first case. We'll begin with a 69-year-old female who's had a greater than 10-year history of rheumatoid arthritis, who presents to her rheumatologist with a rheumatoid arthritis flare. She has 4 tender and swollen joints. Over the years, she's been treated with several cocktails of disease-modifying drugs. Today, her labs show a CRP of 20 milligrams per liter, a total cholesterol of 162 milligrams per deciliter, LDL of 95, HDL of 52, and triglycerides of 74. Her rheumatologist starts her on tocilizumab, which is an interleukin-6 inhibitor commonly used to treat rheumatoid arthritis. Moving forward, 3 months later, after starting the interleukin-6 inhibitor, she reports that she has had great response and her joints have improved significantly. Repeat lipid panel shows a total cholesterol of 229 milligrams per deciliter, notably an LDL of 132 and an HDL of 79 and triglycerides of 97. So the point of this case is to discuss what happens to the lipid panel in the setting of ongoing systemic inflammation and what happens to lipids when you treat it. And with that, back to you.
So this is, in my clinic, I see a lot of patients who have an autoimmune disease, many of them who have rheumatoid arthritis, and patients with rheumatoid arthritis tend to have a higher risk of cardiovascular disease. But then on top of that, many of these patients with rheumatoid arthritis have underlying systemic inflammation and have a lot of inflammatory proteins or cytokines which are circulating. And when patients with rheumatoid arthritis are highly inflamed, their LDLs or their cholesterol profiles can actually get lower, and we'll talk about why that is later. Then as you treat the rheumatoid arthritis and you have inflammation resolution, the cholesterol profiles can actually change. And so this patient, it's not like she was all of a sudden eating more or gained a lot of weight in this flare, but it turns out that LDL and HDL will actually increase as you target inflammation in patients with rheumatoid arthritis. And we'll, again, in the next slides, we'll talk about why that may be the case and really what to do about it. Go to the next case.
Okay, in case 2, is it coming?
Need to push to case 2.
Okay, perfect. We have a 38-year-old male who has recurrent pericarditis presenting to the ED yet again, having failed traditional therapies. He has severe pleuritic chest pain with dramatically inflamed CRP of 263 milligrams per deciliter. Pericarditis is confirmed by an MRI. A year prior to this flare, in 2023, his LDL was high at 170 milligrams per deciliter, and he was advised to focus on lifestyle modifications, mainly, of course, diet, being that activity and exercise is limited due to the pericarditis. During his hospitalization in 2024, his lipid panel was checked and his total cholesterol was 154, LDL 101, HDL 41, and triglycerides 60. Reports that outside of a few days before admission, he really had not changed his diet or weight. And due to recurrent pericarditis, he has started on the interleukin-1 inhibitor rilonacept. And at a follow-up appointment in 90 days, his total cholesterol is now 254, LDL 193, HDL 56, and triglycerides 56.
So this case is a patient who previously had a high cholesterol, an LDL of 170, and he was living a very healthy lifestyle at the time. Then he developed pericarditis, was admitted to the hospital with a flare, and this is an MRI showing late gadolinium enhancement of the pericarditis, and the arrow sign is showing where the pericardium is. Just the fact that you can see that pericardium means it's very thick, and it really lights up, so to speak. It's really uptaking a lot of contrast in the pericardium, indicating very high levels of inflammation. A lipid profile was checked when he was in the hospital, and his LDL was really quite low. Then we treated his inflammation with a biologic targeting the underlying process in pericarditis, and his LDL skyrocketed up. And so this is, I think, an extreme example of what I was showing in the last patient, where when the patient, and we can actually prove it because we had a lipid profile before he was inflamed, where his LDL really plummeted, and then really shot back up after we treated the inflammation. Now, this is something called the lipid paradox, where for a variety of reasons, you can get a falsely lowering LDL in inflamed states. And the reason I brought this case up, and I think it's so important, is people think that this lipid paradox or this lipid relationship with inflammation is present across all diseases. And it turns out that's probably not the case. We do see it in rheumatoid arthritis. I presented this case because I think you can see it in pericarditis. You actually don't really see it in psoriasis or psoriatic arthritis. So this lipid paradox is really disease dependent, but you have to be aware of it when patients have some underlying inflammation. So the lipid paradox was actually initially described in rheumatoid arthritis. And what it was really meant to demonstrate, though, was this paradoxical relationship between the degree of LDL inflammation and cardiovascular risk. And these slides indicate that actually the lower the cholesterol in patients with rheumatoid arthritis, the higher the risk of a cardiovascular event. And so that was the technical and true definition of the lipid paradox concept. But now I think a lot of us tend to take it that, well, the lipid profile kind of changes in underlying inflammation. And one of the take-home messages from this is that if you're going to check the lipids when someone's highly inflamed, which is okay, you should really repeat it and check it when they're not inflamed. And this is going to actually influence some of our guidance statements in the future in terms of when we're supposed to risk stratify these patients with underlying systemic inflammation. You can go to the next slide.
Let me ask you a question before we go to
Sure.
the polling question.
Yep.
You know, both of these cases, they have a autoimmune disease or something that's going to be with them for a while, and inflammation doesn't go to zero, I guess, and even if you treat them with immune modulating drugs, but their LDL cholesterols, both of them are not perfect, particularly for age and maybe for their risk. They both are primary prevention, particularly the younger guy who's probably going to be dealing with his problems for a while. But at what point do you make a decision? At least the younger guy probably has polygenic hypercholesterolemia anyway. At what point do you make a decision about looking at the long-term lipid treatment, such as initiating a statin over the long term, for either for the 69-year-old woman or for this 38-year-old guy?
Right. And so I think it's a great question, and I'd love to hear from others in the panel as well. But I think you're getting some bias because I'm fundamentally a preventive cardiologist. And so I believe wholeheartedly in primordial prevention. And so with this, the easiest is this 38-year-old with pericarditis. You know, we saw that the lipid profile, he had a significant dyslipidemia before the pericarditis. He had even more significant dyslipidemia after the pericarditis. And part of that may have been through the IL-1 inhibitor itself and not just so much of inflammation resolution. But regardless of the underlying disease, I think once you cross that 190 threshold, in my mind, there's no debate, and we obviously treated him with a statin to bring his LDL down.
Yeah, well, what I'm trying to figure out is that do rheumatologists understand this, and do they just treat the patient for their inflammation and they don't send them to a preventive cardiologist? Like Jorge, what do you think? What would you do?
Well, you know, I agree where Michael ended up. I'd have a very low threshold for using a statin in a case like that. And certainly in that first case, the LDL is quite elevated. In the second case, you probably just even on the basis of age would qualify if you did the prevent risk calculator. Another interesting thing for patients like this with rheumatologic disease, now really endorsed by the guidelines, which I've been doing for a long time. In an Epic chart or whatever electronic medical record you have, if you just searched on calcification, you would probably see in patients like this that they've had prior CT scans that would show incidental calcification in the vasculature. And at that point, you might easily say, well, that's really good enough for me, and approximates an incidental finding of vascular calcification, tells you what dedicated coronary imaging might show, and is evidence for atherosclerosis, and would trigger a more aggressive response to LDL lowering, even in parallel with what may also be this additional driver for cardiovascular risk.
Yeah,
Right.
yeah.
Dr. Jones, one thing that I think is very interesting that we don't really focus on much, but is that chronic inflammation does suppress the cytochrome P450 enzymes. And when you treat it, you get upregulation of them. And the drugs that are more metabolized by 3A4, like simvastatin, atorvastatin, may not be quite as effective. Whereas rosuvastatin, if you have good renal function and can use it, is minimally affected by 3A4. You might get more effect by using it. I mean, it is in the package inserts of all these biologic medications.
I think that's very important to understand, is that so most of these immunomodulating drugs do affect cytochrome P450, and that may make such as high intensity atorvastatin not your best choice, and you might consider more rosuvastatin for patients at high risk then, correct?
Correct.
Okay, that's awesome. Okay, well let's go to this polling question. You've probably been sitting here for a while. So which rheumatologic disease is most strongly associated with accelerated premature atherosclerosis and increased cardiovascular risk? Osteoarthritis, fibromyalgia, rheumatoid arthritis, gout, or both? Both C and D. Michael, what do you think?
Sure, and I think on the polling I don't see E, but I think E is the right answer. So rheumatoid arthritis, I think is one of the first autoimmune diseases that was really described to accelerate atherosclerosis. And for all these autoimmune diseases, I generally think it's a synergistic component of the traditional risk factors and the underlying inflammation. So even if the disease is not technically associated with a higher prevalence of traditional risk factors, rheumatoid arthritis patients who are a little more senior do get it often. And so those are the ones that also have the higher traditional risk factors, and also age is a strong risk factor. So really with rheumatoid arthritis, it's a higher TNF, IL-6, other pro-inflammatory cytokines and immune cells that tend to accelerate risk. And then gout, additionally, is an independent risk factor for cardiovascular disease. I don't think it's nearly as well studied, but there are plenty of epidemiologic studies that show it. Whether it's from uric acid or some of the crystals from gout, they've actually found in plaque. Well, that's a little controversial, but we think there's many reasons why patients with gout tend to have a higher risk of cardiovascular disease, and those patients with gout also have a very high prevalence of traditional cardiometabolic disease. So that's why I'd go with in this C and D.
Okay, awesome.
Michael, can I ask you one of the intriguing things that an SGLT2 inhibitor can do is lower uric acid levels, and is that a potential benefit? We've had a couple of papers suggesting that. Would you, from your perspective, sort of say, well, that potentially makes sense about sort of the wasting of uric acid?
Yeah, and I think I mean I'm a massive fan of the GLP-1. I try whenever I can get in my patients without diabetes, whenever I can try to get them approved. I do, especially when they are obese. And so I've seen some pretty dramatic responses. And as you know, adipocytes are highly pro-inflammatory. and secrete a lot of TNF. And so I think in are immune activating and can activate other cells such as neutrophils and monocytes. And so I think for those reasons, targeting cardiometabolic disease and gout and rheumatoid arthritis is incredibly important. Love to hear your take on it too.
Yeah, I think that's true, and we'll get that to in the case that I'll discuss. But I was raising the prospect that the SGLT2 inhibitors
Oh, sorry, yeah.
have a lower uric acid.
Right.
I mean, I know there's a lot of attention on GLP-1s, but in this particular
I heard
case,
select in terms of what you did, and my mind went immediately to GLP-1s because that's kind of where I think these days. But yeah, the SGLT2 inhibitors as well. I think you're right. They can also lower blood pressure, which I think is important in these gout patients. And as I'm sure you're well aware, there's such a big CKM push right now and these patients have so many other coexisting comorbidities that I think there's probably very low. You probably have to go searching very little bit to find a good reason to put an SGLT2 inhibitor. And I know certainly in my own practice, I've been checking more and more microalbumin for those indications. I'm not sorry.
Right.
I got distracted by the gout and cardiometabolic disease
Yeah.
references select.
So finish up on this, Michael.
All right. So I wanted to go briefly through the mechanisms of how patients with underlying systemic inflammation may have a change in their LDL profile or the lipid profile. And this is one, it's a small study, but I actually kind of like it because it went through the kinetics of how IL-6 inhibitors and IL-6 may change the LDL receptor and lead to different catabolism of LDL. And as you target IL-6, that's one of the reasons, because of changing in the LDL receptor, that you can actually get an increase of LDL when you decrease IL-6. And I think Jorge is going to go a little bit more into depth in the Lp(a), but we also see some really exciting change in the pharmacokinetics of Lp(a) when you use IL-6 inhibition as well.
That's awesome. Next slide.
So hopefully this is a good learning point to what I just said.
It is. What is the most likely reason that the patient's LDL cholesterol increased after starting biologic therapy? The patient felt better and started eating more. Targeting inflammation in rheumatoid arthritis can raise cholesterol. IL-6 inhibitors are shown to impact lipid profiles. And B and C. That's correct.
Great. So
Awesome.
the reason I think this is a nice question is because I don't know if we can go back to the question for 1 second. There are in rheumatoid arthritis, we do see this lipid paradox with other biologics as well. And then with IL-6 inhibitors, there is a slight impact of the lipid profile when giving IL-6, but that's not to say you shouldn't give it. These changes oftentimes don't have to be dramatic. And so just to know that after starting any therapy, it's worth just repeating in a few months if you're trying to drive the L down very, very low.
All right, next slide.
Okay, case 3. We have a 25-year-old male with systemic lupus and a positive ANA. He has nephritis and arthritis. His lipid panel in 2020 showed moderately elevated total cholesterol of 283, LDL of 143, HDL 125, and triglycerides were 74. 4 years later, in 2024, total cholesterol is 743, LDL 590, HDL 131, and triglycerides 73. There's 2 very important things that happened to our patient. 1, he progressed to nephrotic syndrome with up to 3 grams per day of proteinuria. And secondly, he was misinformed by reading online that he could benefit from an intense ketogenic diet consisting, well, for him, he chose primarily red meat and bacon, leading to a massive saturated fat load. So the combination obviously had a huge deleterious effect on his LDL. And Dr. Garshick talked about that.
Yeah, I think this is another case. This is a case that we would see in our cardiorheumatology clinic, but it's certainly not a common one, although I think it's something that we have to be aware of, and that, how important taking a history is when you see these patients, and how it's important to remember all of our internal medicine and not just cardiovascular disease. And this is a scenario where I think looking for other causes beyond just genetics or beyond just some mild lifestyle issues is so important. And so this patient, he developed pretty significant proteinuria, and he had this again trending into a nephrotic range proteinuria. And so you can get that. I'm by no means an expert in nephrosis and dyslipidemia, but you can have increased biosis and decreased catabolism, and also decreased lipoprotein lipase activity as well. And that led to some of those dramatic changes. And you can get these even without going to the ketogenic diet. But in this gentleman who decided that he wanted to target his inflammation rather than by medicine, but by dietary changes. And I think doing dietary changes to target inflammation is great, but he went towards a very high saturated fat ketogenic diet. And in this one study from Matt Budas group that looked at the impact of different diets on LDL cholesterol, you can see compared to one diet, the ketogenic, you can see these pretty dramatic increases in LDL, but that's being driven by a very high saturated fat intake. So for this gentleman, he just was misinformed. And so once we spoke to him about his ketogenic diet, and once we treated his nephrosis, his lipids did get better. But again, as a preventive cardiologist, this process to treat his proteinuria took years. And so we also started him on a statin as well to bring down his LDL, given how high it was. We didn't want to wait.
Yeah, this is a pretty dramatic situation. I mean, most of us have probably seen LDL double with nephrotic syndrome. So if it was 120, it might go to 250, or 150 and go to 300. But to go that high because of the ketogenic diet on top, I guess it must have been a couple of things. I've had some patients do ketogenic diets, but not all meat. They've done poultry and fish, and their LDLs don't go up. Their triglycerides go down, their weight goes down, but their LDL doesn't go up. So I guess saturated fat's an important part, but it's probably got to be an interaction here with nephrotic syndrome as well to have an overproduction of LDL and decreased metabolism somehow, because that's an incredibly high LDL.
Yep.
We certainly have seen these cases of people on ketogenic diets really bumping up their LDL levels. It's interesting that some of them tracking their ketone productions and trying to get to certain levels of them. And some of those people, as they will find online, things that support the idea of, yes, my LDL is very high, but that LDL is very large and buoyant and is not dangerous, and we'll stick to it. We really try and move them away from that notion, given the fact they often will still have ApoB levels that are elevated. They may not be as high as you would see in other folks, and of course the nephrotic syndrome, will often track hypertriglyceridemia as well.
Yeah, it's a very difficult thing to treat and to improve their lipids in. Yeah. Okay, next slide. Oh, all right, Jorge, your case.
Okay, well, this is I think a informative, interesting case because the retrospectoscope is helpful for all of us in thinking about what I would have done back then earlier and how it might have mattered. Now, I'll go quickly, as hard as it is for Chloe to keep up with this, but this is a case that is returning for follow-up at 64. And so let's go backwards as one looks at his chart. When he was 56, he was hypertensive. His BMI was elevated. He declined the primary care physician's interest in starting a blood pressure medicine. As we often will hear from patients, his chart lays it out. He's just joined a gym. His LDL is 130. His triglycerides are on the high side. And as we often see, the HDL is a little bit low. A year later, he still has that dyspnea on exertion. He's still hypertensive. His BMI is higher. And now he's finally gotten on to antihypertensive therapy. It's getting titrated. He's on hydrochlorothiazide. His LDL is still in that similar kind of range. Triglycerides are a bit higher, and you could say now that he has prediabetes with an A1C of 6. He has LVH on his EKG, which is another sign of potential risk. And on his echocardiogram, his LVH was noted back then with some evidence for heart failure preserved ejection fraction, but it's still preserved. And moving on, now here he is at 59. He's presenting in the emergency room, and living in Boston, this is not an uncommon scenario of chest pain while shoveling snow, and he's having an NSTEMI EKG that supports that. His LDL is 145. His troponin is positive. He off to the cath lab where he has coronary disease. The left anterior descending is thought to be the culprit. he gets an intervention on that. He has coronary disease elsewhere. His right circumflex has 60% RCA, and now he's going home on a whole bunch of medicines. He's atorvastatin 80, further titration of his antihypertensives. He's on antiplatelet agents. And so let's move on. So there's his prior history, and so he gets discharged there at 59 with his LAD PCI. At 60, he's doing well. He went to cardiac rehab. He lost weight. He feels well. More data has been coming out. His LDL 69, he gets ezetimibe added. His LDL is down to 53. Great. His triglycerides are better. And over the next few years, he doesn't have any specific issues. Of course, as we often see, his weight comes back on. He keeps his LDL in a good range. His A1C is still on the high side, 6.2. That weight had come back on. His lipoprotein little a is 95, sort of on a nanomole scale, so less than 75. So not, terribly elevated, but certainly above that range of being less than 75. And now he's back in clinic. He's having some increasing dyspnea on exertion, chest pressure while he was on vacation. And he, of course, gets sent to stress tests, and he has a reversible perfusion defect on his stress test. And so next, if we move on, he goes on to elective cath, and his LAD stent looks okay, but has progressed in his right coronary, and he has 50% left circumflex. And now he undergoes intervention on that RCA lesion, lines up with that inferior perfusion defect. And now, he poses, if we go on, a kind of question that we wrestle with. He says, hey, doc, I just had another stent placed, and I thought I was doing great. Why am I having progressive disease? And what's interesting is to look back when he was 60, his CRP was elevated at 3.8. And the kind of signal that is associated with this kind of evolution. And so this poses this question in this very common kind of scenario arising over many years and now recurrent disease in this patient. Is inflammation and chronic low-grade inflammation part of the problem? And we can ask a couple other questions about that if we move on. When did that start? If you had checked an hsCRP when he was 56, would you have seen it? Or when he was 57 or 59? And is that a modifiable component to his risk? Is it just a way of maybe risk stratifying him? Or could you, and say that there's risk there, but if you lowered his CRP, could you change outcomes? And if you're going to treat him and treat that hsCRP as an indicator of chronic inflammation as an input to his risk, how do you go about that? And so that really, I think, sets up what we've been thinking about, and been a lot of data around this. So if we move on, I'll run through some of this, and of course Peter will interrupt me as we go. But in that black box, it's not a black box. It's a known box about classic risk factors. There's some others you could add to this, but here are the core ones. And these are the things that we think are associated with driving that normal arterial wall into the one that has atherosclerosis in the middle. This classic image from Peter Libby, the Scientific American, lays this out till ultimately not just atherosclerosis, but the atherosclerotic complication of there having been, in this case, plaque disruption. Those very pathways that Michael was laying out so nicely have been at work here and disrupted the plaque. And if we go on to the next slide, it raises this polling question about what inflammatory biomarkers might be most commonly associated with increased cardiovascular risk. And this process of atherosclerosis, A1C, SID rate, high sensitivity CRP, it's a different one, or ApoB. And so, Peter, I think our audience is spot on, and they're sort of setting up some of the discussion. Well, is that elevation in hsCRP just downstream of the ApoB, or is there something else at work here?
Yeah, I think that's the case. I mean, in this particular situation, it looked like fairly early on he was showing signs of cardiometabolic syndrome. He had low HDL, high triglycerides, he had borderline A1C. That was before the CRP was born and he was done. So he's probably had a mixture of metabolic risk as well as inflammatory risks that were preceding the onset of his disease, and it obviously continued afterwards, and even continued with his LDL under 60 milligrams per deciliter. So that brings up the question about how much further do you lower his ApoB? So let's move on to the next slide.
Yeah, I think, this story did start, roughly 10 years ago. Have some of those perspectives changed? If you've been looking at his non-HDL, would you have been motivated to start treating earlier? If you'd send him off for imaging because you're wringing your hands over, did he need a statin or not? Those are all things. But, we've had a lot of evidence in this space epidemiologically. So here's one of the more recent papers from Paul Ritker at our institutions, nearly 28,000 healthy U.S. women and 30 years of follow-up asking their first MACE. And you see here, hsCRP, LDL, and lipoprotein(a). And in terms of, discerning and risk across these quintiles, you can see that the evidence that's there in the blown up graphs for hsCRP, there's no doubt LDL matters and it is predictive of risk. And we know it's a directly modifiable risk factor. Lp(a) getting a lot of attention. You see that these quintiles, group a little bit more together with Lp(a), but at high levels, it's quite associated with risk. Next slide. And we've had, evidence that when you look at the statin trials at LDL and hsCRP on the left to prove it. So this is, full dose of atorvastatin versus pravastatin, and on the right, A to Z trial, and you segregate out recurrent myocardial infarctions or death, what you see is that the highest risk is when the LDL was elevated and the CRP was elevated. And when the LDL was less than 70, the CRP was less than 2, that was the lowest risk in both these trials. I think what's intriguing on the left is that we certainly would have paid attention to, and the evidence has borne out, the need to pay attention to the patient with elevated LDLs and a CRP that's low, but it's an overlapping line in the people who had a CRP greater than 2 and an LDL less than 70. And this is, part of the story, part of the provocative aspect of the data that says that maybe hsCRP can tell you something about someone's risk and that maybe it's a modifiable target.
Yeah, so, this was also shown in the Jupiter trial as well.
Yes, and there's so much data there that I've only picked a couple of highlights because I understand that the lipid panel goes to 9 o'clock, not 1 o'clock in the morning, or we could keep going because it's a very straightforward assay. And of course, the case has been made where there's many indicators or markers of inflammation. That's true. But hsCRP is reproducible, reliable, and cheap, and certainly allows for these kinds of studies, and maybe its utilization in a lot of different settings. Now, statins lowering CRP is just one of the therapies that can do that. Next slide. This shows the data for an agent we already talked about, which is low-dose colchicine. And we have here on the left the Lodoco-2 and Colcott, and you can see here how the decreased incidence in events with colchicine. On the right is clear synergy, which created, again, placed in a black box. You could say it's in a black box, so we're trying to sort out. Here, colchicine did not make a difference on outcomes. It was a different patient population, more acute scenario presentation. But these discussions are ongoing about colchicine and maybe another way of modifying inflammation.
Yeah, well, I think the clear synergy was a colchicine initiated within 30 days or 60 days after an event, whereas Lodoco and Colcott were more stable atherosclerotic cardiovascular disease. And has the FDA approved colchicine at 0.5 milligrams for this?
Yes. And so it's available. It's out there. There's the FDA indication to reduce MI, stroke, coronary revascularization, cardiovascular deaths in adults with established ASCVD or multiple risk factors. For CVD, it's in the 2025 ACC scientific statement as an adjunct. Not to use in acute ischemia, or you could say based upon clear synergy, shortly after an event. Mechanism may be NLRP3, inflammasome, decreasing IL-1, IL-6, and CRP. Biological basis for that. You do have to be careful with it, and maybe Laura will comment on, the metabolism aspects here. It's, not the most straightforward of medicines to use, but in a patient who's having recurrent events and you're thinking about maybe the evidence through HSRP that there's risk being driven and progressive disease being driven by it, it is an option.
Yeah, well, this I don't think is being used very much in preventive clinics, and maybe because lipidologists and preventive cardiologists aren't as familiar with it, and also because there are probably some side effects for patient tolerability. So, Laura, why don't you talk to us about maybe some of the downsides of taking colchicine?
Sure. Well, I do think that the uptake of it in the preventative cardiology and secondary prevention has been somewhat slow. And I think it's a multitude of reasons. One is I think we do have a lot of years of experience of using it in acute scenarios like pericarditis, where we see, a little bit more difficulty with tolerability, diarrhea, worried more about drug interactions. We do have to be worried about drug interactions with colchicine. It is metabolized by the 3A4 and dependent on P-glycoprotein transport. So any drugs that affect any of that really should not be given with it, such as the azole, the antifungals, clarithromycin, some immunosuppressants, ritonavir, which is in Paxlovid. We see that a lot. So if those drugs are going to be used, certainly colchicine has to be held. Then we also need to think about dose matters. If you'll go, to this slide, dose does matter. And in the US, we have the 0.6 milligram, which is cheap. It's readily available. The 0.5 milligram, of course, as was earlier stated, is the one that is approved for stable coronary artery disease. And 0.6 and 0.5 doesn't sound that much different, but it really is a 20% difference. And when you look at this pharmacodynamic study from 2023, you can see that the safe upper limit of colchicine is 3 micrograms per deciliter or per liter. And in the patients who were on the 0.5 milligram daily dose, really there was great tolerability. But when you go up to the 0.6 milligram daily dose, the upper limit threshold for colchicine toxicity is exceeded even when there's mild renal impairment. So you have to really be aware of renal impairment. And so a lot of these patients are older. They may have some renal disease. I think there is a place for colchicine to be used. And I think it's like in the case we were just looking at, it may be a really good place. But you have to think about it. You have to be watchful of things. I do know it's off label, but some providers will give the 0.6 milligram like every other day or 4 days a week or something like that. So it's more affordable because Lidoco is brand name. If you have commercial insurance, you can use a copay card and make it very affordable. If you're on a Part D plan and you're on multiple meds, you've met your deductible, you've met your max out of pocket, you can add the brand name 0.5. But if you're one of those people that's somewhere in the middle, it's expensive. So trying to figure out a way to give them an anti-inflammatory without having drug interactions and diarrhea and causing other problems, it's a lot to think about. So
okay, that sounds great. Jorge, why don't you finish out this thing?
Yeah, and so, SELECT raises some interesting questions. The evidence that semaglutide versus placebo in people with overweight or obesity but not diabetes had cardiovascular benefits. Next slide. And here's that primary endpoint. And important to note that, the majority of these patients, some 90%, were on statin therapy. The baseline HSCRP around 1.8. and of course, very well treated cohort, but yet you still had this 20% reduction in events. Next slide. And when you look at wrestling with the question about why was there benefit in SELECT, if we
Keep going. Next slide.
that there's a modest change in systolic blood pressure. The LDL really didn't change much. There was about a 15% reduction in triglycerides, but let's look at the hsCRP, a 37% reduction in hsCRP in patients with baseline hsCRP of 1.8. Now, it was associated with the benefit. You're going to see a couple papers hopefully coming out soon looking specifically at this issue, mediation analysis and hsCRP paper, but they both sort of indicate a relationship with the effect of the GLP-1. Given how common those issues are, it becomes relevant in this case we were just discussing about, well, was his increasing BMI, his prediabetes, might have these have been things that were contributing to his hsCRP and were potentially modifiable, including, I think importantly, I would encourage participants to think about the ways in which very high hsCRP may be predictive of catastrophic events like cardiovascular death. They're interesting story within that.
Well,
Next slide.
this is interesting about GLP-1. He's not that big. He's not, his BMI is under 30, but he does have prediabetes and probably cardiometabolic syndrome. And, the GLP-1s might be helpful, but he also has HFpEF and prediabetes and everything. So here we get back to why not use an SGLT2 inhibitor with him?
Yeah. There's only been the data's been more limited about effect on hsCRP, but there is some of that, and you could say that could be an option. Certainly, he had dyspnea on exertion, and often you'll see that better in patients. That what you have a little bit less of evidence for is that you're going to change atherosclerotic complications and MACE kinds of events.
Right.
Now, and the other thing that's impressive, and you can understand the discussions about the cost of these agents and how that's going to shift over time as more become available, that SELECT enrolled patients with a BMI over 27. And so at his BMI in that 30 range, he really falls into the range of patients where you say SELECT is telling me something about how I might modify this gentleman's risk. And keep in mind, we're talking about how we might have modified it after his first presentation. He had already declared himself to have active clinical coronary disease, and so you would really want to get after it. And the idea that most of the therapies we've been talking about now, arguably colchicine is a direct intervention on inflammatory pathways, but in terms of statins and other drugs we could talk about, it's often indirect. And so all that data prompts the idea of, well, why not treat more the drivers of inflammation? And certainly there's been evidence for IL-6 as being associated with cardiovascular risk and a direct signaling molecule contributing to that. And so all that data we're talking about has set up the hypothesis that if you directly modify the mediators, we don't think hsCRP is a mediator of risk. It's just a marker. And so IL-6 has risen as one example of that. On the next slide, you see the trial and the data that we can look forward to is in ZEUS, looking at ziltivekimab as an antibody to IL-6. And that this builds off, prior data with IL-1 beta antibody that showed without a change in LDL, an intervention on inflammation could decrease cardiovascular risk. And so I think this will be an important trial to further the idea that inflammation is a modifiable, not just a risk stratifier, but maybe a modifiable contributor to atherosclerotic complications. And so, this is eagerly awaited. They have included in these patients with can be enrolled based upon they're having CKD and the UACR you see there, and EGFR. So this will be, I think an important further step in this. Next slide. I think that may be this is some evidence that maybe IL-6 inhibition will have an effect on lipoprotein(a). I don't think I'd put this in there, but I think it's intriguing about maybe therapeutic action, and so much interest in the possibility that LP(a) may be acting in part through its own pro-inflammatory action.
Right. Well, that gets back to his initial situation. When you talk about further lowering LP(a) and maybe, reducing inflammation, his LDL was 50 or so. Why shouldn't he be considered an extreme, like the European guidelines would say, and his LDL needs to be below 40? So he needs to maybe get a PCSK9. That'll lower his LP(a) a little bit. It'll also lower his LDL 50% and may have a little bit of effect on inflammation.
Yeah.
What do you think?
Yeah, I think, I'm definitely supportive of the idea that lowest is best, but when you look here at his overall arc, I think there's evidence to suggest that maybe that hsCRP is telling you about something about him. I think he does provide a good example of the potential for GLP-1 interventions of having an effect on HFpEF, on his atherosclerotic risk, on his CRP, maybe helping a little bit with blood pressure. And there's sort of multifactorial aspects to his disease, but certainly there'd be nothing wrong with, continuing to progress and advance his LDL lowering regimen. I'm not sure that you would then see his hsCRP come down. He's got quite a ways to come down to be even at the 1.8 seen in SELECT, where further lowering had benefit. But I think it's intriguing possibility that maybe there's an opportunity there. And I think just, might, among the other factors going on with this patient, would an hsCRP, when he had his first PCI, have alerted those caring for him of we can't just assume that this guy's going to do great because we got his LDL down. And
Right.
And maybe it would point to the idea that you need to do more for him to avoid that second event, which fortunately in this case was elective and not more serious.
Right. Well, this ends up getting to a difficult set of discussions. You're talking to a patient about, okay, all these blood pressure medicines you're on. Now we're going to add maybe another lipid lowering agent. We want to add an injectable once a week. That's for your weight reduction. Oh, well, maybe we'll add an injectable also to lower your LDL even more. And the patient's going, what? He goes, no, I'm not going to do all that stuff. I hear you can take supplements that'll improve your inflammation and your immune status and all that. Laura, what do you say when patients say, well, what about supplements? Don't those things work for inflammation?
Every day. We hear it every single day. And they have very strong beliefs about their supplements, and likewise have very strong opposition sometimes to traditional medications, especially statins. So, when I'm asked, I try to build trust and recognize that, they're influenced by something, and sometimes it's other providers. And, they think these things are on the pharmacy shelf and they're marketed to be good for decreasing inflammation and fixing everything. So what I do try to do is give evidence that we do have. So I look at Memorial Sloan Kettering Cancer Center has a great integrative medicine site that gives all kinds of information about supplements. Natural Meds does, and so I'll try to give them some evidence. Look, these do have evidence of having drug interactions and affecting some of your other medications. They do have side effects. I mean, specifically when we look at over-the-counter fish oil, ginseng, turmeric, garlic, berberine, red yeast rice, lots of these things, they can increase the risk of bleeding. They can have drug interactions. So I have a statement I use all the time, and it's that we cannot guarantee the safety and efficacy of supplements since they have not been studied in randomized controlled trials, and the purity and consistency of the products are not regulated. And I put it in every chart when I'm asked about it and say, if you choose to use these, please be cautious, watch for side effects. But it's tough. It's really tough. And they're willing to spend a lot of money on them when they're not willing to pay for their PCSK9 monoclonal antibody or their GLP-1. So it's tough,
Yeah.
but I try to
Yeah.
meet them where they are, give information that I can, and then
Yeah, put them on the drugs work. That sounds great. We need to back up one slide and do our final polling question. Inflammation contributes to atherosclerosis by promoting endothelial dysfunction and plaque formation, increased HDL production only, increased complete inhibition of oh boy, this is a
I
little
think
different.
you
It's
got
different.
a little glitch there, but
Yeah, complete inhibition of macrophages or elimination of vascular smooth muscle cells. A, B, C, D. We got a poll?
uh, I know that there's going to be a couple questions there, but I think
Well, it is number A.
yeah.
That's clearly the answer, and the final slide sort of gets that. We're coming near the end of our time here.
Yeah, and I think we can get on to some of the questions because I think this is just a recap of this
It
idea.
is. And one of the questions is for you, Jorge. Somebody asked a question about, does PCSK9 lower or dull the effects on interleukin 6?
Well, the data's been a little bit mixed. It seems like in more chronic scenarios, basal levels of IL-6 are not shifted greatly. And people are having more acute inflammatory issues. There may be more of an effect when there's a stronger input around inflammation. There was more preclinical cellular evidence that there was an effect of PCSK9 on reducing IL-6 and inflammasome activation. So I'd say we'll continue to track this. We'll have more data around PCSK9, the oral agents, but I don't think it's a dramatic effect on basal IL-6.
Oh, okay. All right. And I don't think we have any other questions in here. We really are right down to the end. Guy, are we done with the amount of time we have available?
We have about a minute, so maybe George and Michael, if you could answer those last few questions. I think Michael, there's one about pericarditis, and Jorge, there's one on IL-6. But I want to say thank you for everyone joining us this evening. This was a discussion, as Dr. Plutzky said, that could continue to 1 in the morning. I think we did a nice dive into inflammation and cardiovascular disease and extends to cardiometabolic disease. I want to thank Dr. Plutzky and Dr. Garshick and Laura Gantt for joining us tonight, and Peter for being a super moderator. And I look forward to seeing everyone at the NLA meetings in Chicago. And again, please send in topics or ideas. Anyone who wants to participate to be a panelist, let us know. So with that, have a great week, and thank you everyone for tuning in tonight.
Thank you.
Thank you.